So those of you who have questions for Dr. Vermorken, we'll try to have time for those during this discussion period. I thought we'd start off with just a brief case presentation and get some views of how to proceed at certain points in this case from our expert panel. This is a 73-year-old man with a history of a T4, N2C, M0 squamous cell carcinoma of the base of tongue that was P16 positive. The patient received 71 gray with simultaneous integrated boost IMRT. The gross disease was treated at 2.15 gray per day with weekly cetuximab, and the patient completed therapy in late 2010. However, the patient developed a left neck recurrence approximately 2 years later. This is the original tumor. You can see the left base of tongue tumor that it was involving the deep root of the tongue and proceeded to the oral cavity as well as to the upper aspect of the left piriform fossa. That was treated approximately 2010. 2 years later, the patient developed this left-sided neck recurrence. And I don't have all the slices here, but the radiologist felt that this involved the thyroid membrane. And the question arises, how do we proceed next? And I'd like to ask our panel your thoughts on this.
Assuming that there's no metastatic disease, I mean, surgery definitely should be considered for that. I guess the question is what would be the extent of surgery. There seems to be involvement of the skin there. There's also some real concern about the larynx as well. So again, surgery would be a preferred modality, but it's likely to be extensive.
Oops.
I did learn that this is my patient. But pretending I don't know who this is.
But actually, you left UAB before this happened, so this is news to you.
Oh, it is?
Yeah, I think so. Maybe not.
So this gentleman, it's difficult to base a surgical decision on a CT scan alone. It's very important to include the physical exam, and so it's really helpful to understand the mobility of that mass and how it relates to the larynx. It may appear that there is some involvement of the cartilage there, but if it's mobile, then I would have more hope that a laryngectomy would not be needed.
Great. Well, that was the feeling of the tumor board, and if we could proceed. There we go. The patient proceeded to neck dissection and required a pectoralis muscle flap reconstruction. The pathology revealed a 5-centimeter left neck mass with extracapsular extension and gross invasion of subcutaneous tissues, lymphovascular tumor emboli, and positive margins. The larynx was spared. It did involve the thyroid hyoid membrane, and a portion of the hyoid was removed. So next, how would you proceed? Brian?
So I guess what we don't have here is how this was closed and reconstructed, because I'd be talking to Pierre or Scott anxiously and hoping you're going to bring in new tissue in there when you do the resection.
Is that what you said?
Yeah, it's a pectoralis flap.
Yeah, I'm sorry. Okay.
Yes.
So in that situation, I mean, with this patient has got two obvious problems facing them, apart from the intensity of the management that's happened already. But the finding of these lymphovascular tumor emboli is very, very worrying, and the positive margins, obviously, for the local disease problem. So we would ordinarily offer a post-operative course with a continued extended course to get to at least the type of dose that can sterilize microscopic disease, and we would use smaller dose per fraction for that. But we would be very, very keen that our medical oncologists get involved here, not just because of the local regional problem, but in our experience, and we were talking about this earlier, 44% of these patients who have a positive margin at the time of the neck dissection will have a risk of distant metastasis at least, and it's probably greater than that for the recurrent setting. So this patient has got a serious risk of distant metastasis based on these two characteristics.
So, Brian, what would your radiation dose be?
Well, I mean, our usual, if it wasn't going on a protocol, which I think is what one should follow, but there isn't one right now that we're involved with. So we would deliver 1.1 gray twice daily and get the dose up to the order of 55 gray for a situation like this.
So, Jan, what are your thoughts about systemic treatment? This is a patient you saw, 73 years old, has a performance status 70 to 80 range, KPS, had an angioplasty several years ago, not on very many medicines right now.
Well, on everything that Brian was saying, I agree with that. I mean, I think that the patient has a chance of developing distant metastasis. I think the indication for chemoradiotherapy or bioradiotherapy in these circumstances is correct. When you have positive margins, it's certainly an indication. I think that that's one of the rare indications that you will use chemotherapy with radiation. I think then still you have to use an optimal dose, but one of the questions that I had to you is, why did the patient did not receive concurrent chemoradiotherapy the first time?
The patient was originally.
This patient? No, he did not. He received radiation with cetuximab.
Oh, with cetuximab. It's not my case, so I don't recall. I don't recall the thought process at that time, but I do think there was a concern about high-dose cisplatin with his situation, his previous heart disease. He was fairly obese at the time of. He had almost morbid obesity at the time of his diagnosis, from what I can tell from the notes. And during the 2 years between the initial treatment and the recurrence, he lost about 100 pounds, and he's actually in better shape at this time.
But I think that in the situation that we are now, I think that if you're looking for a dose of cisplatin here, I can understand that, considering his age, that you would go for a weekly regimen, but then 30 to 40 milligram is absolutely necessary. You need to go up to 200 milligram per meter squared in total dose, at least, if you want to have an effect. I think lower dosages is not guaranteed that it might have a beneficial effect.
Right. Well, our medical oncologist felt that with his KPS not being terrific and some former heart disease, that he wasn't a great candidate for high dose. So he ended up going on to IMRT at 150 BID with weekly low dose cisplatin as a radiosensitizer. But I hear what you're saying about the interest, if you can get the higher dose in, that would be preferable. It was not felt to be the case for him.
Can I ask a question?
Sure.
So the question I have is, say you've offered this patient re-irradiation with chemo, and the patient isn't willing to accept the re-irradiation risk. Would you give him chemo alone?
Well, that's
Considering that he's got extracapsular spread,
Yeah.
lymphovascular invasion,
yes.
This is a patient who's at high risk of getting a recurrence.
Yes. Well, this patient had an HPV-positive tumor, right?
Yes, sir.
So in principle, I think that the patient might have a chance that is chemosensitive, is possible. And there was an interval of about 2 years. So yes, if the patient would, after discussion, agree to receive chemotherapy, I think you could do that. You have something that you can evaluate, so it might be an option.
Brian, in your institution, would you do the same?
Well, I suspect my medical oncologists might bring the hammer down on this. They don't normally give chemotherapy in that setting as a sole treatment. But I'd be very surprised if a patient like this did not want to. This is not as long as it's been well covered, I think that the risk here is not as great as some of the things I was talking about earlier with skull base and using stereotactic type treatments. I think with a moderate dose, which is this kind of dose, a 60 gray type regimen, given twice daily with sufficient 6-hour apart type treatment, so you get the repair that you want, you should be able to get through this without, I guess his biggest problem is a failure of the disease happening at the carotid and blowing it out because of that, rather than the radiotherapy. I think he has to understand that. And it's not that difficult a treatment for the patient, I don't think. Am I right? Did this patient have trouble getting through this?
He had some trouble, yes.
Yeah. From
Straight,
radiotherapy?
yeah, it was straight through 150 BID, but he ended up healing well and doing fine afterwards. But these are the PTVs for treatment.
But I think that there is a French trial reported that if you're giving inadequate radiation, you better not give it. So it's very clear. Then you can still use. There was a randomization. The study was stopped too early, so it's difficult to make a final statement. But the outcome of inadequate radiation versus simple methotrexate was exactly the same, which much less toxicity of the methotrexate. Now, that's not the treatment I would suggest if the patient would refuse radiation. I would try to find a better regimen for this patient. I have some examples where even with locoregional oropharynx cancers, you patients could have a prolonged benefit of chemotherapy. But, of course, I would agree that the primary choice would be reirradiation with an adequate dose.
We have some questions from the audience here.
I just observed that the recurrent site was a little unusual. It's in the central compartment, overlying the thyroid cartilage. It's very unusual when you get recurrence, it's solitary recurrence in the neck. My question to the radiation oncologist, Brian, what field would you treat for this patient as far as radiation is concerned? What would you include both sides? And to begin with, what type of neck dissection was done for this patient? What was the extent of the neck dissection? All levels?
It was a fairly it was a selective neck dissection with a more advanced dissection in this area, taking the thyroid hyoid membrane, and a portion of the hyoid was involved. These are the fields that we ended up using. The red line represents the PTV, so we encompassed the area where we felt there was tumor, and perhaps a little more, but not much. It was a very defined field.
And just in terms of the volumes, we'd probably be a little bit smaller than this, I think. I don't see the...
I wasn't sure why my colleague went to the lower neck. There might have been something in the surgery that directed her to do that. But you're right, it could be a little smaller.
Yeah, the concern we would have would be the brachial plexus when you go down.
Right.
We're guided a little bit by the University of Michigan data, which suggests that you don't have to be as wide as traditional radiotherapy has to be when you're dealing with the recurrent setting.
Other questions, and they don't have to be about this case. Just questions for the panel.
I have two questions regarding this case. First of all, was the initial treatment of bioradiotherapy compared to chemoradiation for this patient or not?
He was discussed at our tumor board, and it was decided to give him cetuximab and radiation. I suspect at that time that his medical conditions were more favorable for a cetuximab radiation regimen.
I suppose that. Second, what the operation discussed with the patient doing a laryngectomy and a permanent tracheostomy or not? Because I didn't expect that the margin would be negative in the first place. So, do you share the patient?
At the recurrence time?
No, I mean the operation. I did not do a frozen section control, so I did not expect, looking at this CT, that I would get a negative margin. So was the decision of doing an laryngectomy with the patient discussed with him before the operation?
And you're talking about the operation for the recurrence?
Yeah.
Yes. I believe it was discussed. I think the surgeon felt that he did get a good gross total resection, and there wasn't a tumor extending to the larynx, but it turned out the soft tissues had a positive margin. So.
It's difficult to say what the surgeon's discussion with the patient was, but in general, the discussion for laryngectomy should have been made. I'm certain it was in this case, but I would have had a discussion of possible laryngectomy with the patient. You agree?
Oh, I agree entirely.
I think you did, actually, Scott, at the beginning. Other questions for this case, or any questions to the panelists, please? Barbara?
This is more a comment than anything else. I think one of the things that has to
Those are good points.
Can I comment on the comment? I was kind of glad to hear Dr. O'Sullivan saying that in Toronto, they would not consider palliative chemotherapy for that population. I can tell you that at my institution, if we tell patients that we should not treat them, that they would go across the street or they would go in another town and someone is going to give them chemotherapy. So I think the medical oncology colleagues have to kind of self-regulate what they do. And,
Yes, but what Barbara is saying is very important. I think,
absolutely.
first of all, in this sort of circumstances, it's important whether the patient has symptoms or not. You cannot just simply ignore if a patient has serious symptoms, and you have to discuss whether you would just do a palliative measure or you would use an anti-cancer treatment. That's what you openly have to discuss, and I agree that you have to inform them. That's also why I showed you the data on PFS and survival, because that is something that patients don't realize really when you discuss treatments. So first of all, this was an HPV-positive patient. That may be any way that the patient may have a prolonged survival even in these circumstances. The second is whether the patient is symptomatic or not. And the third is an open discussion, which I completely agree with. And that means that I would not routinely use patients, give chemotherapy in these circumstances, but individually, depending on how the patient is responding to what you're saying, you can make that decision.
I think we have to stop there as we're over time. And I thank you all for coming to our session.